Welcome back to the deep dive. Today we are scrubbing in.
We are.
We're stepping through the sterile doors, masking up, and walking right up to the operating table for a procedure that is, well, simultaneously the most routine and one of the most deceptively dangerous operations in general surgery.
That's the perfect way to describe it.
We are carefully opening Chapter 71 of Baily and Love's Short Practice of Surgery, the 28th edition.
It is the absolute classic text, isn't it? For generations of surgeons, it's just been the Bible. And the chapter we are dissecting today is the gallbladder and bile ducts.
Exactly. Now, before we make that first incision, let's set the mission parameters.
Okay.
This deep dive is built for you, for medical students, for surgical trainees, and really anyone who wants to understand the mechanics of their own body. Our goal here is to decode Chapter 71.
Right.
We want to give you the mental hooks, the visual anchors, and, the metaphors to make this dense material stick. We aren't just reading the book to you. We are interpreting it.
Well, we have to drop the standard disclaimer right up front. This discussion is an interpretation. It's a study aid. It is absolutely not a replacement for the text itself, and it certainly isn't a replacement for formal surgical training.
Right. Don't code a podcast in the mortality and morbidity meeting.
Please don't. Think of this as your ready reckoner, or maybe a high-yield revision tool for your commute to the hospital.
So let's start with the why. Why are we spending the next 40 minutes talking about a little pear-shaped sac tucked under the liver?
Because it is the ultimate trap for the complacent surgeon. Cholecystectomy, removing the gallbladder, is one of the most common operations performed globally. It feels routine.
It's just the bread and butter.
It's the bread and butter of general surgery. But the anatomy of the biliary tree is incredibly unforgiving. It is a region of high variance. You can do 100 of these surgeries perfectly, and on the 101st, the anatomy will look completely different.
And if you don't recognize that variance,
the consequences are catastrophic. We aren't talking about a minor complication.
No.
We're talking about cutting the main bile duct, which is a life-altering, sometimes life-shortening injury. It's high volume, but very, very high stakes.
That is a volatile mix. So here's our roadmap for today. We're going to start with the terrain, the surgical anatomy and physiology, specifically the danger zones that Baily and Love highlight.
Okay.
Then we'll move to the pathology, the stones, the sludge, the chemistry behind them.
Right.
We'll walk through the surgery itself, specifically the laparoscopic cholecystectomy and the safety culture that has developed around it. And finally, we'll look at the congenital and malignant conditions, the things you cannot afford to miss in a child or an elderly patient.
And we've got some fictional case studies lined up to test your diagnostic skills as we go.
Let's jump into Section 1. The terrain, surgical anatomy and physiology. Most people know the gallbladder stores bile, but it's not just a passive bucket, is it?
No, absolutely not. It's a very active organ. Think of the gallbladder as a high-powered industrial dehydrator.
A dehydrator, I like that.
The liver produces bile continuously, about 40 milliliters an hour. When it leaves the liver, that bile is like 97% water. It's dilute. But the gallbladder takes that liquid and sucks out the water, the sodium chloride, and the bicarbonate.
It concentrates it.
Massively. It concentrates the bile by 5 to 10 times. So it turns a dilute flow into a potent, thick detergent designed to break down fats.
So it's a holding tank that supercharges the contents.
Exactly. And that concentration process is actually key to understanding why stones form later, but we'll get to that.
Anatomically, the text describes it as pear-shaped, roughly 7.5 to 12 centimeters long. The capacity is small, only about 30 milliliters. But for the surgeon, we don't just see a pear. We divide it into 4 key sectors.
Right. You have the fundus, that's the bottom, the rounded end that projects from the lower border of the liver. You can sometimes feel this through the abdominal wall if it's enlarged.
Okay.
Then the body, then the neck. And finally, the infundibulum, also known as
Hartman's pouch?
Hartman's pouch, exactly, which is the funnel leading into the duct.
And the neck leads into the cystic duct. This is where things get technical and honestly a bit architectural. The text mentions some specific structures inside that duct that can be a headache for surgeons.
You're talking about the valves of Heister.
It sounds like a character from a fantasy novel or a piece of German engineering. The valves of Heister.
It does, doesn't it? These are spiral mucosal folds inside the cystic duct. They aren't true valves that open and shut like the mitral valve in the heart.
So what are they?
They're more like a spiral staircase or a corkscrew.
Mm.
They stop the duct from kinking or collapsing, ensuring bile can flow in and out.
But I imagine they can be a problem.
Oh, for a surgeon trying to thread a catheter in there to take an x-ray during surgery, they can be a nightmare. You get snagged on the corkscrew.
And surrounding the wall, you have the sphincter of Lütgens.
Right. These structures regulate flow, but they also define the anatomy we have to dissect. It's a heavily guarded gateway.
Let's talk about blood supply. In surgery, knowing where the red stuff comes from is usually rule number one.
It is. The main player here is the cystic artery. In a textbook world, which, as I said, we rarely live in, it branches off the right hepatic artery.
Typically.
It typically arises behind the common hepatic duct.
But, and this is a massive but, in the text, the anatomy here is notorious for going off script.
It's the Wild West. The cystic artery can come from the left hepatic artery, the gastroduodenal artery, or directly from the aorta in rare cases. But the variation that keeps surgeons up at night is the caterpillar.
The caterpillar turn, also known as Moynihan's hump. Paint that picture for us.
Imagine the right hepatic artery. This is a major vessel supplying the right side of your liver. You do not want to cut this.
Definitely not.
Usually it runs straight and deep, but in some people it becomes tortuous. It loops down, looking like the humped back of a caterpillar, and it dips right into the area where you expect the small, disposable cystic artery to be.
It invades the workspace.
It does. It can lie very close to the gallbladder neck. So if a surgeon is working on autopilot, assumes that any vessel in this area is the cystic artery and clips it.
They ligate the right hepatic artery.
Exactly. You've just cut off the blood supply to half the liver. That is a major, major injury. That's why we use the visual anchor of the caterpillar. If you see a loop, pause. Do not cut the caterpillar.
This leads us directly to the holy grail of gallbladder surgery, the one geometric shape that dictates everything, Cowlitz triangle.
Or, as we tend to call it in modern laparoscopic surgery, the hepatocystic triangle. The boundaries are critical. You need to visualize this clearly, listeners. Close your eyes if you aren't driving.
Okay, what are they?
The triangle is bound by three things: the cystic duct inferiorly, the common hepatic duct medially, and the inferior surface of the liver superiorly.
Cystic duct, common hepatic duct, liver. Why is this triangle the focus of the entire operation?
Because that is where the treasure is, and that is where the danger is. Inside this triangle is where you usually find the cystic artery. It also contains the lymph node of Lund.
The node of Lund, another great name.
It's the sentinel node for the gallbladder. It acts like a beacon. It often lies superficial to the cystic artery. If you find the node of Lund, you know the artery is likely just underneath or behind it.
But the real reason is safety.
The reason we obsess over this triangle is safety. The classic error in gallbladder surgery, the one that leads to lawsuits and ruined lives, is mistaking the common bile duct for the cystic duct.
Because they look similar.
Under inflammation, yes. They are both tubes. If you pull on the gallbladder hard, you can tent the main bile duct up, so it looks like the cystic duct. If you clamp and cut the common bile duct, you have disconnected the liver from the gut.
What a disaster.
By strictly identifying the boundaries of the hepatocystic triangle, you ensure you are working on the branch, the cystic duct, not the trunk, the common duct.
The text also mentions a safety landmark called the R4U line. This sounds like a droid from Star Wars, but I gather it's a lifeline for the surgeon.
It's a critical line of defense, especially when things are messy and scarred. R4U stands for Rouvier's sulcus to segment 4 umbilical fissure.
Okay, break that down. Rouvier's sulcus.
It's a groove or a cleft on the underside of the liver, usually on the right lobe. It's actually where the right portal pedicle runs. It's visible in about 80% of patients.
And you draw a line from that.
You draw a line from that sulcus across to the umbilical fissure where the round ligament enters, and you have the R4U line.
And the rule?
The rule is stay ventral, stay above and in front of that line. The cystic duct and artery lie ventral to the R4U line. The common bile duct, the danger zone, lies below or dorsal to it.
So if you're digging below the R4U line...
You are in enemy territory.
Enemy territory, that is a visceral way to put it. It instantly tells you where not to be.
You have to think that way. The moment you cross that line, your internal alarm should be screaming.
So let's do our first check-in question for you, the listener.
Right. Let's test that visualization. Can you picture the boundaries of the hepatocystic triangle? Cystic duct, common hepatic duct, liver. Now, add the R4U line.
Where is the danger?
If you can't strictly picture where the common bile duct sits in relation to that line hint, it's below it. Hit pause. Rewind if you have to. Look up figure 71.3 in the text or find a diagram online.
Because the rest depends on it.
The rest of the surgery depends on getting this geometry right. If you don't know the map, you can't drive the car.
Let's move from the anatomy to the problem itself. Section 2. The stones. Cholelithiasis. The source says 10 to 15% of the Western population has them. That is a huge
It
number.
is massive.
That's 1 in 10 people walking down the street.
It is. But here's the kicker. 80% of those people are asymptomatic. They have stones sitting in their gallbladder, rattling around, doing absolutely nothing. We call them silent stones.
And the rule for those asymptomatic people.
Generally, leave them alone. We treat people, not pictures. We don't operate on incidental stones unless there are specific red flags.
For instance.
For example, if they have a porcelain gallbladder where the wall is calcified and looks like an eggshell on X-ray, that carries a risk of cancer. So we take it out. Or if the patient has sickle cell disease, because distinguishing a sickle cell crisis from cholecystitis is a nightmare, so we remove the gallbladder prophylactically. But for the vast majority, if it isn't hurting you, we don't hurt it.
Let's break down the stones themselves. Not all stones are created equal.
No. In the West, the vast majority, about 80%, are cholesterol stones.
And how do they form? Is it just eating too many burgers?
It's a bit more complex. It's a recipe for disaster called the triangle of formation. You need 3 ingredients.
What are they?
First, supersaturation of cholesterol in the bile. Second, too little bile salts and lecithin to keep that cholesterol dissolved. And third, gallbladder stasis.
Stasis meaning it's not emptying.
Exactly. If the gallbladder is lazy and doesn't squeeze often enough, the bile just sits there. The cholesterol precipitates out like sugar at the bottom of a cold cup of tea. It nucleates, and a stone is born.
That's a great image. Sugar and cold tea. What about the other types, the non-cholesterol stones?
Those are pigment stones, and they come in 2 colors, black and brown. And the color tells you a story about the patient's physiology.
Let's start with black.
Black stones are small, hard, and jagged. They look like little pieces of coal. They are sterile, meaning no bacteria. They are made of polymerized bilirubin.
And we see these in specific conditions.
We see these in conditions where there's too much breakdown of red blood cells hemolysis. So patients with sickle cell anemia, hereditary spherocytosis, or patients with cirrhosis.
Okay, so black equals blood breakdown. What about brown?
Brown stones are soft, greasy, and earthy. Unlike black stones, these are associated with infection and stasis.
So they're not sterile.
Not at all. You find these when there's a blockage, like a stricture in the duct, or a foreign body, like a stent that was placed previously. Bacterial enzymes break down the bilirubin, and it precipitates as calcium bilirubinate.
So brown equals bacteria. That's a solid mnemonic. Now, let's talk about what happens when these stones wake up and choose violence. The clinical presentation.
It's a spectrum of disease. It usually starts with biliary colic.
Colic.
This is a mechanical problem. A stone gets washed into the neck of the gallbladder and gets stuck. It blocks the exit.
The door is jammed.
Right, yeah. The patient eats a fatty meal. The gallbladder tries to squeeze to push bile out, but it's squeezing against a closed door. That builds up pressure and tense pain in the right upper quadrant.
But then it resolves.
Eventually, the gallbladder relaxes, the stone falls back into the main bag, the blockage clears, and the pain vanishes.
It's the ball valve effect.
Exactly. Pain comes, pain goes. But if the stone stays stuck, if it wedges in there and doesn't fall back,
Then you've got a bigger problem.
now you have acute cholecystitis. The mucus and bile are trapped. The chemical composition changes. The wall gets inflamed, swollen, edematous, and eventually bacteria start to grow.
And this is where we see the famous Murphy sign.
Right. And I want to be clear because students often get this wrong. Murphy's sign isn't just pain when you press on the belly.
No, it's specific.
It's a specific dynamic test. You ask the patient to breathe in deeply. As they inhale, the diaphragm moves down, pushing the liver and the inflamed gallbladder down into your fingertips.
And then?
The patient will suddenly stop breathing. They'll just catch their breath because the pain of that inflamed organ hitting your hand is so sharp that inspiratory arrest is the positive Murphy sign.
The text lists some terrifying complications if this process goes untreated. 2 really stood out to me: Merizi syndrome and gallstone ileus.
Merizi syndrome is a fascinating anatomical misfortune. It's a case of bad neighbors.
How so?
Imagine a large stone gets impacted in the gallbladder neck or the cystic duct. It's so big and the inflammation is so severe that it presses externally against the common hepatic duct, which runs right next to it.
So a stone in the gallbladder causes jaundice by squashing the main bile duct from the outside.
Precisely. It can even erode through the wall and create a fistula between the gallbladder and the common duct. It's a surgical nightmare to fix because the tissues are just fused together.
And gallstone ileus, this one always boggles my mind.
It's a misnomer, really. It's not an ileus, which implies paralysis of the bowel. It's a mechanical obstruction.
So what happens?
A very large stone erodes through the wall of the gallbladder, directly into the duodenum. It bypasses the bile duct entirely.
It acts like a wrecking ball.
It tumbles down the small intestine. It's usually too big to pass through the narrowest point of the gut, which is the ileocecal valve, so it gets stuck there.
So you have a bowel obstruction caused by a gallstone.
Correct. And there is a classic radiological triad for this, known as Wrigler's triad.
What's in the triad?
1, you see small bowel obstruction on the X-ray. 2, you see a calcified stone in the intestine, if you're lucky. And 3, and this is the key, you see air in the biliary tree, or pneumobilia.
Because the fistula lets air from the gut travel up into the liver ducts?
Exactly. If you see air in the bile ducts and a blocked bowel, think gallstone ileus. It's a classic board exam question.
Incredible. Let's apply this. We have a fictional case study to sharpen our listeners' instincts. Let's call her Mrs. Miller.
All right, lay it out.
Mrs. Miller is 45 years old. She has a high BMI. She comes into the ER late at night after a heavy meal. Let's say a bucket of fried chicken.
The classic trigger.
She has severe right upper quadrant pain radiating to the tip of her right scapula. And crucially, she has a fever of 38.5 degrees Celsius.
Okay, let's unpack this. The demographic fits the classic teaching female, 40, fertile, fat, the Fs, associated with cholesterol stones.
Right.
The meal is a trigger fatty food, releases cholecystokinin, which causes the gallbladder to contract.
What about the pain radiation, tip of the right scapula?
That's classic referred pain. The inflammation irritates the diaphragm and the phrenic nerve, which shares nerve roots, C3, C4, C5, with the shoulder area. It's a somatic link,
Okay.
sometimes called Boas sign if there is hyperesthesia there.
Okay.
Now, the key differentiator here is the fever.
Explain that.
Biliary colic, the simple ball valve blockage. Hurts like hell, but it doesn't usually cause a fever. It's just mechanical pressure.
Right.
A fever suggests inflammation and possibly infection. Mrs. Miller has moved past colic. She has acute cholecystitis.
So how do we confirm it? Do we just book the OR?
Not yet. Ultrasound is the gold standard. We are looking for 3 specific signs.
Which are?
1, gallstones. 2, a thickened gallbladder wall, specifically greater than 3 millimeters. And 3, pericholecystic fluid, which is edema or fluid leaking around the organ. We also look for the ultrasonographic Murphy's sign, where she winces when the probe hits the gallbladder.
The source mentions the Tokyo guidelines for grading severity. Where does Mrs. Miller fit?
The Tokyo guidelines are great for standardizing care. They grade from I to 3. Grade 1 is mild healthy patient, mild inflammation. Grade 3 is moderate. This means a high white cell count greater than 18,000, a palpable mass, or symptoms lasting longer than 72 hours.
And grade 3?
Grade 3 is severe. That means organ dysfunction, hypotension, confusion, respiratory failure. If Mrs. Miller is just in pain with a fever, but her blood pressure is stable and she's alert, she's likely maybe grade a second, depending on her labs.
Okay. Check in question number 2 for our listeners. Let's twist the case. Let's say Mrs. Miller also had jaundice. Her eyes are bright yellow. What does that change, and what tests do you order next?
Excellent question. Listeners, think about the anatomy.
Yeah.
Simple cholecystitis is inflammation of the gallbladder only. The main road, the common bile duct, is open. Bile flows from the liver to the gut just fine.
So you shouldn't be yellow.
You shouldn't be yellow. If she's jaundiced, the stone might have moved. It might be in the common bile duct. We call that coliductolithiasis.
Or Maridzi.
Or she has Maridzi syndrome compressing the duct. You cannot go straight to surgery yet. The next test is an MRCP magnetic resonance cholangiopancreatography. It's an MRI that gives you a roadmap of the ducts to see if a stone is blocking the main pipe.
Why is that so important?
If you miss that stone and take out the gallbladder, she stays jaundiced and can get sepsis.
Got it. Okay, let's assume the MRCP is clear. It's just the gallbladder. Mrs. Miller needs surgery. Section 3, the intervention. We're performing a laparoscopic cholecystectomy, or lap chole.
The gold standard, but we start with preparation. Prophylactic antibiotics at induction, usually a second-generation cephalosporin like ciforaxone, to cover gram-negatives and anaerobes. We check coagulation profiles.
The patient is on the table under anesthesia. How are they positioned?
Reverse Trendelenburg. That means head up, feet down, and rotated to the left.
And why is that?
Gravity. We want the heavy liver and the colon to fall away from the right upper quadrant, exposing the gallbladder so we have room to work.
Now, the surgeon is in, the ports are placed, the camera is rolling. What is the primary objective before any cutting happens?
The goal is to achieve the critical view of safety, or CVS. This is the non-negotiable commandment of modern biliary surgery. It was popularized by Strasbourg to stop people cutting the bile duct.
Describe the CVS. What exactly does the surgeon need to see on the screen?
You have to dissect the hepatocystic triangle. You clear out all the fat, the fibrous tissue, the lymph nodes. You don't stop until you see exactly two structures entering the gallbladder.
Only two.
Only two. The cystic duct and the cystic artery.
And you have to see the liver plate, too.
Yes. You must see the bottom third of the liver bed, the cystic plate. This ensures you aren't just looking at a window in the tissue, but that you have fully mobilized the gallbladder from the liver.
I like the metaphor of wiring here.
It's exactly that. Imagine you are diffusing a bomb. You don't cut a wire until you have stripped it, traced it back, and confirmed 100% that this is the power cord, the artery, and this is the data cable, the duct.
And if there's a third wire?
If there is a third wire, or if you aren't sure, or if it's covered in goop, you do not cut.
But sometimes you just can't see. The inflammation is too bad, it's a mess of scar tissue. The text talks about bailout strategies.
This is about safety culture.
Yeah.
We use the Be Safe landmarks to help us orient. Bile duct, sulcus of Rouvier, artery, fissure, enteric duodenum. But if you cannot achieve the critical view of safety, you must stop.
Don't be a hero.
Do not be a hero. Heroism in the gallbladder cuts the bile duct.
So what are the options if you're stuck?
Option 1. Convert to open surgery. Sometimes getting your hands in there provides tactile feedback the camera can't give, although in modern practice, if you can't see it with a scope, open surgery is often just as hard.
What's option 2?
Subtotal cholecystectomy. This means you open the gallbladder, remove the stones, and cut away the loose part of the bag, the fundus and body. But you leave the neck that is fused to the danger zone.
That sounds safer.
It's much safer. You sew it up or drain it. It's better to leave a piece of gallbladder wall behind than to cut the bile duct.
And option 3?
A cholecystostomy tube. You just stick a drain into the gallbladder, let the pus out, and fight another day when the inflammation is settled. It's not a defeat, it's a strategic retreat.
Because the alternative is the nightmare scenario. Bile duct injury.
It is the most devastating complication. It happens in about 0.5% of cases, 1 in 200. The Strasbourg classification helps us categorize these injuries.
What's the range?
They range from type A simple leaks from the cystic duct stump or minor ducts of Luschka to type E, which is complete transection of the main duct.
If that happens, if you realize, oh God, I've cut the main duct, what do?
You stop immediately. If you aren't a specialist hepatobiliary surgeon, you usually don't try to fix it right there.
Why not?
Because simply repairs done by non-specialists often fail and cause strictures later. You place a drain and refer the patient to a tertiary center. They might need a Roux-en-Y hepaticochenostomy, a major reconstruction where they bring a loop of bowel up to the liver to create a new drain. The first repair is the best chance for success.
It really emphasizes that this routine surgery demands immense respect. Let's shift gears to section 4, congenital anomalies and pediatrics. This is where we deal with structural problems from birth.
The big one here is biliary atresia. This is a condition where the extrahepatic bile ducts are progressively destroyed or absent from birth. It's an inflammatory obliterative process.
How does this present?
Jaundice in a newborn.
Oh,
But be careful. Many babies are jaundiced physiologically. The red flag is jaundice that persists after the first 2 weeks.
and there are other signs.
Yes, the key signs. The stools will be pale chalky or clay-colored because no bile is getting to the gut to color them brown. And the urine will be dark, like tea.
And there is a strict timeline here.
This is critical. Listeners, if you take one thing away for pediatrics, take this. The treatment is the Kasai portoenterostomy. Basically, the surgeon attaches a loop of bowel directly to the porta hepatis of the liver to drain bile.
But timing is everything.
It is. If you do this operation before 8 weeks of age, 60 days, the success rate is decent. If you wait longer than 8 weeks, the liver fibrosis is often irreversible. The Kasai will fail, and the child will likely need a liver transplant.
So persistent jaundice in a baby is a surgical emergency.
Absolutely. Do not sit on it. Do not say, let's check again in a month. Investigate immediately with an ultrasound and HID scan.
What about cholelocystic cysts?
These are congenital dilations of the bile ducts. We use the Todonic classification. Type I is the most common, a fusiform or spindle-shaped dilation of the extrahepatic duct.
Is this just a cosmetic issue, a wide pipe?
Far from it. These cysts are cesspools for bile stasis. They lead to stones, recurrent infection, and most importantly, they have a very high risk of malignancy.
Cholangiocarcinoma.
Exactly.
So you can't just drain them.
No, you have to excise the cyst completely and reconstruct the tract, usually with a Roux-en-Y loop. If you leave the cyst wall behind, you leave the cancer risk behind.
And there was one more condition mentioned, Caroli's disease.
Caroli's is type V in the classification. It's multiple cystic dilations inside the liver intrahepatic. It's rare, often associated with congenital hepatic fibrosis and kidney issues. It's a very difficult condition to manage, often leading to liver transplant.
Moving to section 5, tumors. We've touched on cancer, but let's dive deeper. Cholangiocarcinoma bile duct cancer.
This is a tough diagnosis. It's uncommon but aggressive. We classify them by location. If the tumor is right at the bifurcation where the left and right hepatic ducts meet high up in the liver hilum, it's called a Klatskin tumor.
What causes these?
Chronic inflammation is the theme. Primary sclerosing cholangitis, or PSC, is a major risk factor. On biopsy, PSC shows this classic onion skinning fibrosis around the ducts. It's also strongly linked to ulcerative colitis. So if you have a patient with UC who starts getting jaundiced, you need to worry about PSC and cholangiocarcinoma.
And the source mentions parasites.
Yes, specifically Clonorchis sinensis and Ascaris. These are liver flukes and roundworms common in parts of Asia. They live in the ducts, cause chronic irritation, stones, and eventually cancer.
Now, gallbladder carcinoma. This brings us to a famous surgical law, Courvoisier's law.
This is a favorite exam question and a great clinical pearl. Courvoisier's law states, in a patient with painless jaundice, if you can feel a palpable gallbladder, it is unlikely to be gallstones.
Walk us through the logic. Why wouldn't a stone make the gallbladder palpable?
It's about mechanics and history. If a patient has had gallstones for years, the gallbladder is scarred, it's fibrotic, it's shrunken, it cannot stretch. Okay. So even if a stone blocks the duct, the gallbladder won't balloon up to a size you can feel through the skin.
That makes sense.
But if the blockage is caused by a tumor, say cancer of the head of the pancreas or the distal bile duct, it happens in a gallbladder that is likely previously healthy and elastic. So as the pressure builds from the blockage, the gallbladder distends like a water balloon. You can feel it.
So palpable gallbladder plus jaundice equals cancer, usually. Palpable gallbladder plus pain is more likely an empyema or acute cholecystitis.
Exactly. The painless part is key for the malignancy.
Let's apply this to our final case study. Mr. Singh.
Huh?
Mr. Singh is 70 years old. He comes in looking very yellow, but he says he's fine, no pain. Maybe he's a bit itchy.
Pruritus.
Pruritus from the bile salts depositing in the skin. He's noticed his stools are pale and silver-colored. On exam, you feel a mass in the right upper quadrant. It doesn't hurt him when you press it.
This is the textbook presentation of Courvoisier's law.
It sounds exactly like what we just described.
It is. This is unlikely to be a stone. This is likely a malignancy obstructing the distal common bile duct, probably pancreatic head cancer, or a distal cholangiocarcinoma.
What's the next move?
He needs imaging. A triple-phase CT scan, or MRCP, to stage the tumor. We need to see if it's resectable. Can we cut it out?
And then the prognosis.
Often poor, unfortunately. These present late because they're painless. But if it is resectable, the surgery is massive. Often a Whipple procedure or pancreatic choduodenectomy, where we remove the head of the pancreas, the gallbladder, part of the stomach, and the duodenum.
It's a sobering reality.
It is. But recognizing it early gives the only chance for a cure.
We are reaching the end of our deep dive. Let's bring it all back together. What are the key takeaways for the listener to lock in?
First, anatomy is king. Respect the hepatocystic triangle and the R4U line. Visualize the caterpillar. If you don't know where you are, stop. Second, stones are common, but differentiate the symptoms. Colic comes and goes. Cholecystitis stays and inflames with fever. Third, safety first. The critical view of safety prevents bile duct injuries. If you can't see two structures and the liver plate, you do not cut.
And finally,
in kids, don't miss biliary atresia. The window of opportunity closes at 8 weeks.
I like the metaphor you used during our prep, the check engine light.
Right. The biliary system is forgiving until it isn't. It can handle stones for years asymptomatically. But when the light comes on, pain, fever, jaundice, you have to act correctly. And anatomically, it requires you to be a defensive driver.
Right. Assume there's a hidden danger.
You assume there's a capillary artery or a hidden duct until you prove otherwise.
Here is a final provocative thought from the source material. We touched on asymptomatic stones. The rule is do not touch. But with the rise of laparoscopic surgery being so minimally invasive, are we intervening too much, or are we preventing future Mrs. Millers?
That is the debate. Every surgery has risks. Remember the 0.5% bile duct injury rate? Is it worth risking a life-altering injury to prevent a colic attack that might never happen? For now, the evidence says, let sleeping dogs and sleeping stones lie.
A powerful thought to end on. This deep dive was just the map. Now you have to go read the territory. Open Baily and Love, Chapter 71. Look at the diagrams of the Strasbourg injuries. Look at the HID scans.
Visualization is everything in surgery.
Absolutely. Stay curious and keep diving deep.